Hello, welcome to another edition of Turnover Time, an effort brought to you by the AAST Associate Member Committee, as well as the AAST Associate Member Education Committee. Today, we have the first iteration of our highlighting of the AAST committees. We have the honor today that our first committee highlighted will be the Military Committee. As you know, the Military Committee has been leading the front in terms of military trauma excellence, research, and continued development of both our military active and reserve clinicians. And we greatly appreciate their time for joining us on Turnover Time so we can highlight the work that some of the AAST members have been doing. Today, we're going over a recent publication published in the Journal of Trauma and Acute Care Surgery entitled Finding the Bleeding Edge, a 24-hour mortality by unit of blood transfused in combat casualties from 2002 to 2020. I have with me today Dr. Erica Vizcard. She is an assistant professor of trauma, burn, and critical care at Harborview Medical Center. And we're honored to be joined by Colonel Schreiber. Colonel Schreiber is the Chief of Division of Trauma in the Critical Care and Acute Care Surgery. He's also the director of the Donald Trunke Center for Civilian and Combat Casualty Care at Oregon Health and Science University.
So the objective of this study was to assess the relationship between the number of units of blood products transfused and 24-hour mortality in combat casualties to identify if there is a futility threshold. Their methodology, they did a retrospective review of the Department of Defense Trauma Registry from 2002 to 2020. Inclusion criteria were deployed U.S. military members in active combat who at a medical treatment facility received 1 unit of any blood product. Exclusion criteria were those lost to follow-up at 24 hours. The primary intervention was looking at total units transfused from injury to 24 hours admitted at a medical treatment facility with damage control resuscitation capabilities. And their outcome was looking at mortality at 24 hours and mortality at discharge. So some pearls. Survival for all patients receiving transfusion was 93.3%. There was increasing mortality up to 80 units, and then a decrease between 81 and 100 units with no clear futility threshold. Overall, 28.2% of the patients received more than 15 units. Majority receiving ultramassive transfusion survived at a rate of 79.3%. So, Colonel Schreiber, a few questions for you about your paper. First, what inspired this work?
Well, first of all, I'd like to thank both of you for highlighting our paper. I got to give, of course, most of the credit to Colonel Gurney. This is a product of the HEROES grant. Colonel Gurney is the PI of the HEROES grant, and I'm one of the co-investigators. The goal of the grant is to look carefully at blood transfusion during the conflicts in Iraq and Afghanistan, and to sort of really get a good idea of what the best strategies for transfusion are. Take a look at things like whole blood, low titer whole blood, component therapy, and isolate the ideal therapy based on what information we have. This, I think, is a really important paper because futility is such a critical element of managing patients, both in the combat as well as civilian setting. And I think since COVID, especially when we suffered from very serious blood shortages, the question of how many units should we be giving patients really came up, and should we limit the number of units? And during that period of time, there were a number of civilian trials that suggested that there was a futility threshold, and that over a certain number of units, really it would become futile care and we were just wasting blood. This was not consistent with what we have seen in the military setting, where we've seen generally just ultra massive transfusions and lives saved despite huge amounts of blood being given. So we really wanted to take a close look at this in the military setting to see if it would be different than what we were seeing in these civilian papers. And indeed it is. And I would just tell you that this really supports my bias, functioning both in the military and civilian setting. This is my bias when I've been deployed. In fact, this is my bias when I've been at home as well. I have not seen a futility level in the care of patients in either of my practices. So I think this paper, which is somewhat contrary to what's been seen in the civilian setting is a critical paper really in the literature.
Great, thank you. And that kind of leads to the next question of what are the implications for practice?
Well, I will certainly continue to practice the way I have in my situation. I sort of think of it like this. I think of it like I am treating the patient in front of me. And if that patient's exsanguinating, I don't think that numbers of units should be the critical decider of whether or not that patient, whether or not you stop care of that patient. I really think it's more along the lines, are the injuries futile? Is it going to be impossible to get hemorrhage control? Have you gone beyond physiology that is survivable? I think those are the major decision makers. And so in my practice, I really focus on the patient in front of me. I don't so much worry about hypothetical patients that may be coming in. Frankly, I will exhaust the blood supply on a single patient if I think that that patient has a decent chance of surviving. I do think that somewhere during a massive transfusion, there should be a pause and get input from surrounding individuals, anesthesia, others in the room, etc. How are we doing here? Is this a potentially survivable patient? Should we continue? But really, the numbers of units of blood does not play a huge role in that decision making. It's really more the physiology. Am I able to get hemorrhage control? Do I see an end to the case in the future, or have we reached a point where it's futile based on physiology, injury complex, etc.?
Right. And then my last question for you, what are the next steps for your research in this area?
Well, we're going to continue. And again, all of this I have to attest to Colonel Gurney as the PI of the HEROES trial, but really get down into the weeds of the optimal transfusion strategies. And are there differences, for instance, between outcomes in patients who receive fresh whole blood versus low titer whole blood? And how critical is the ratio, for instance, in the component therapy? So, you want to compare comparable things. So if you're comparing low ratio transfusions of red cells to plasma and platelets to whole blood, you would expect those patients to do worse. So I think that the future of the HEROES study is going to really get in the weeds of what are the benefits of fresh whole blood, what are the benefits of low titer whole blood. Does storage affect outcome? Would be another question. Is the age of the low titer whole blood important? And then what about component therapy and what role does it play? So the idea is going forward to really, this is a huge database. There's it's a massive database. So you can answer really important questions effectively with the numbers of patients that are available in these studies. So I think it's a real opportunity to get down to to a real basic level about the best strategies for outcomes after massive transfusion.
Thank you to Dr. Schreiber for that wonderful interview. And now we have the opportunity for Colonel Jennifer Gurney to be joining us. Now, due to travel arrangements, she's unable to join us via video, but she's with us on our audio feed. Colonel Gurney is the chief of the Joint Trauma Systems and is the first author on the paper, which we've previously reviewed. We thought it was more than fitting for her to be able to give her insight on this paper and questions related to its future resources.
All right, Colonel Gurney, I've got a few questions for you. So first, what inspired this work?
Yeah, thanks. And thanks so much for highlighting the Deployed Heroes research team. So what inspired this was sitting in the AAST last year in 2022 and listening to a paper being presented called When is Enough Enough? Odds of Survival by Unit of Blood Transfused. And, COVID really sparked research into looking at blood utilization and blood futility cut points because there were shortages of blood supply. And what the study that was presented at the AAST found is that there was a futility cut point in their patient population and that people should consider stopping transfusion around 36 units of RBCs. And I was sitting there at the AAST listening to this and thinking, this is absolutely not the experience in the military. So we went to our database that's being run. We have a research study called Deployed Heroes, Deployed Hemostatic Emergency Resuscitation of Traumatic Exsanguinating Shock. because, in the military, everything has to be an acronym. And we're really looking at transfusion outcomes, everything from timing. We're going back and re-abstracting over 20,000 records to look at timing and to get detailed information about resuscitation strategies. So it was inspired by the AAST meeting. That's why everyone should go to the meetings. You learn a lot. And we went to our Deployed Heroes database and looked at this question. And it really was not a very sophisticated analysis. We just wanted to know, is there a futility cut point in combat casualties who receive transfusion?
Great, thank you. So my next question is, what are the implications of your findings for practice?
I think there's a couple. I mean, one is that we should think about people who think there's a futility cut point for transfusion. I hope they can have a mindset change and realize that if you have the chance of getting hemorrhage control, and if you're not going to run out of blood, that you should bet on the patient and, do your best to save the patient. In terms of my personal practice, this doesn't really change my personal practice because we don't really have any limitations in transfusion, especially in the deployed environment. And the reason we don't in the deployed environment is because we rely heavily on the walking blood bank. And so most of these patients, actually almost all of them who received over 100 units of blood, the walking blood bank was activated. So that's warm, fresh, whole blood. I think another implication of this study is potentially a mindset change. If we think that in the future that there could be shortages of blood supply, then in the United States, we should also be thinking about having a civilian walking blood bank. And this isn't something that you can just do on the spot. It takes a lot of planning, pre-screening. And so the other implication is, nationally, as part of a national disaster preparedness plan, we should be considering civilian walking blood banks as part of that.
Wonderful. And then my last question for you, what are the next steps for your research?
Well, we're continuing to look heavily at the Deployed Heroes database to understand what is the best transfusion strategy, also comparing low titer whole blood to component therapy and low titer whole blood to warm, fresh whole blood. But the next step from this is to get a better idea of how much warm, fresh whole blood played a role in these survival outcomes in patients who received over 100 units of blood. I don't think that civilian data would show the same thing, that casualties or patients that receive over 100 units of blood have close to an 80% survival. That's certainly not what's coming out of civilian trauma centers. So I suspect that something that we do different, which is giving warm, fresh whole blood, has a role in that. So going back and being much more stringent with the analysis, taking into account covariates, timing of transfusion, and survival bias, I think we can get some better data to understand survivors in ultramassive transfusion.
Well, Colonel Gurney, thank you so much for joining us. And on behalf of the AAST Associate Member Education Committee, we want to thank you and Dr. Schreiber for your wonderful work and the opportunity of joining us on this edition of Turnover Time. And specifically, thank you for making this first iteration of the committee spotlight so successful. We want to thank the members of the AAST Military Committee for obviously their impactful work and how it relates to pre-hospital and hospital transfusion, specifically those receiving fresh whole blood. Thank you once again for joining us on this edition of Turnover Time, and tune in next time where we highlight relative research initiatives, and work done by the AAST committees. My name is Joshua Dilday, and here with me was Dr. Erica Biscard. Thank you once again, and we'll see you next time.